That goes to Jesus' disciples. They all wanted to be next to him, right? It rubs off.
Well, Dr. Hernan Bayar is the host.
Right. Hernan Bejar is from Lima, Peru. His father's got the same name, Hernan Bejar. You know him because he's been to the Curso Interamericano many times. Yeah, outstanding student. He's on his third year, on his way to completing. So Julio Navarrete, who's from Ecuador, and they're listening now, he and Hernan have become the IT, the technical.
Right. Do you remember when parents taught their children? Now my daughter, who's an IT specialist, when things really go bad, I can remotely give her control of my computer. Stuff dances around very quickly and gets fixed. Yeah, you learn from your students, which is important because actually I have a couple of examples of things where listening to your students leads to an advance, and be sure to give them credit.
Yes.
Muy bien.
Hey, Margarita.
Hi, Dr. Palmberg. How are you?
Bien, bien.
I was your first student from Dominican Republic, woman.
Yes. Second, yes, all but one were women, and you were the first woman.
Margarita, you're most welcome. We're getting ready to start now.
Okay.
And at this point, I'm going to share screen briefly. Actually, Paul, why don't you get your screen up? You start sharing it. So it'll be all set. Now that way we're all in key. Then I will be able to, perfect. So leave it there and I can see it. And at this point, Julio Hernan, I will formally open this webinar entitled A Tribute to Dr. Paul Palmberg. I would like to welcome everybody in Latin America, in the United States, and in Europe, who in one way or another have been touched by the friendship or the teachings or the mentorship or the discipleship of Dr. Paul Palmberg. For us here in the Dominican Republic, this is the end of our COHES meeting, COHES meaning cohesive, but meaning Congress for the Hospital Elias Santana. This is the second meeting that we have, of course, because of the COVID-19 pandemic, it has become a virtual meeting. But today, which is the closing day, this is our closing ceremony, we have as a guest speaker, Dr. Paul Palmberg, and also a very interesting interview and participation in our panel of Willie and Janice Hunter with their daughter, Nicole. Because of the special reasons for having this seminar, I have invited Dr. Margarita Arbaje, who is the director of our glaucoma program, and she will have some words to say about Dr. Palmberg as well. And Dr. Carlos Gomez, the first and the only, who was the first graduate in ophthalmology from our residency training program. Without further ado, I would like to introduce Dr. Paul Palmberg's talk on how to plan your life, my experience and humble advice. Dr. Palmberg, most welcome. Let it rip.
Thank you. Are we screen sharing on the right one?
I can see it perfectly what you have, and and your sound is perfect. So the panel can shut down videos and microphones, and we can.
Okay, so thank you so much, Juan, for inviting me. You are one of my academic children of whom I am most pleased. The contributions that you have made are just fantastic. And I suppose maybe the most important thing any teacher does is to help empower people who have tremendous potential along their way. Of course, almost everything they accomplish on their own. But if you get them part way along, it's really satisfying. So I One asked me to share a few things about my life philosophy, what motivates me, as well as at the beginning here, as well as things that I want to share with you about glaucoma and its management, and particularly towards the end, something that I think will completely change how we manage glaucoma in the future. So first, I'm talking about planning your life, my experience, and some humble advice about how you might want to live yours. A lot of my life has been involved in resolving or dealing with paradoxes. You know, and the classical paradox in physics is light is a particle, light is a wave, and then we found out that light is a particle that moves in a wave. And in ophthalmology, a paradox we have is that if we intervene in a patient, it can have benefit, but it can also have risk. And so a lot of what we have been doing in my career and others are doing in their careers in glaucoma is to optimize both, maximize the benefit, know when to intervene, and find ways of reducing the risk. Now, in planning your life, if you're a Christian, you read in the Bible, and some parts of you read about it, it sounds like God's sovereignty is everything and your life is pretty much predestined. And then in other places in the Bible, it sounds like, you've got a big role yourself. You have some freedom to choose and to accept Christ in faith, for example, or to dedicate your life. And you have responsibility to live that life in a productive and helpful way. And we're encouraged to be creative, not to just follow, but to be creative. And that's a very interesting concept. If something's predestined, how do you create? But let's say you're planning your life and you want to commit to follow God's plan for your life. Well, how do you find it? Well, ironically, God then tells you to decide what to do. You don't get a message from heaven. Only if you're being asked to do something you just could not have figured out. It wasn't logical, it wasn't reasonable. Does anybody in the Bible get a special message? Most of the time, as it says in Jeremiah, I don't want to lead you around like a donkey. I want you to understand the principles, and then you make the decisions and you go ahead. So you do need to consider your appropriate desires. You don't need to negate them. God wants them to be met. Your personal ability and your potential. Well, sometimes your potential is something that you really wouldn't have guessed at the beginning. I was very shy in ever giving any talks. I could never imagine getting up in front of a large group of people and giving a talk. And yet I've spent most of my life now as a teacher. Consider the circumstances that come along in life. They may seem kind of random at times. Are they? Or are they somehow part of God's plan? And dealing with them as they come. And then seeking counsel from experienced and trustworthy people can be helpful. And of course, we're aided by biblical stories that set examples of how to live your life and how not to live your life. And this principle, fairly simple one that Jesus said, is seek to glorify God and to benefit others and yourself. You're not left out of that. It's not like Jesus others you that I sometimes hear that you're somehow supposed to negate your life. No, you're supposed to maximize your life. That's actually God's plan. But to seek the things that are beneficial to you in a way that's really beneficial in God's perspective. Well, one of my favorite parts of the Bible, kind of the life motif of my life, has been Ephesians 2:8-10. And of course, it first starts out with the famous verses about, by grace are you saved through faith, and not of yourselves. It is a gift. The faith is a gift of God, not of works, lest any should boast, for we are his workmanship, created in Christ Jesus unto good works, which God hath before ordained that we should walk in them. Now, I'm not a biblical scholar, but I find it very helpful to go back to the original language, to get books that explain what the words mean, and to read commentaries. And it may sound, as you look at this, that good works which have been previously prepared may sound like that's kind of preordained in some way. But from our perspective, very interestingly, and to me at least, in the Greek, it means place in readiness, not to foreordain, not the ways in which they're being done. In other words, the categories of good works were preordained, but what's actually done sounds, at least from this passage, to have a lot to do with you, your insight, your creativity. So I think this means we have a creative role in doing those good works, and you should spend time creatively thinking about your situation. Where can I make a contribution? Maybe even beyond what you might have expected in the past might be accomplished if you are looking for a way to serve your fellow man and in honor to God. Well, let me talk about some turning points in my life. At the age of 6, I heard a sermon about salvation. I thought, well, that sounds sensible. I should certainly want to be in a good relationship with God. So I went and talked to my mother and I said, Mom, can you guide me through this process? So we knelt by her bed and I made this prayer and she guided me into faith. Well, what I did not know was that night my mother and father got together to talk, and my mother said, you know, if we believe this enough to teach it to our kids, then we really ought to commit ourselves to it. And 30 years later, she told me that this was a turning point in her life and my father's life. So you never know what the consequences of some of your actions are that turn out to be incredible. You played a role. I don't know how many things in life you do that somehow affect somebody else in a positive way. Well, my mother went on to be a Sunday school superintendent and was a public school counselor. When we were in Japan from 1952 to 1954, my parents hosted a Bible study for servicemen in their home, who, as a result, were not out getting drunk and carousing in Japan, which a lot of happened. And my father, an ophthalmologist, who in May of 1945 was on a hospital ship going into Karamureta as part of the Okinawa invasion, was feeling bad for himself. He was in his room and he said, gee, all the senior officers were invited to this meeting on the planning, and I wasn't invited. He felt sorry for himself and he decided to go out and get some ice cream. He got out of his room and into the stairwell when the kamikaze hit, which killed everybody who went to the meeting. And when he went back to his room, it was gone. The bomb had gone through his room. Well, that was certainly a turning point in his life. And he might have been bitter against the Japanese, but when we were in Japan, he went out to an orphanage and he found children with congenital cataracts. And he got a Japanese doctor, ophthalmologist with him, and they didn't know how to operate congenital cataracts. And he operated on 60 children and, of course, was teaching this doctor. And this is a role model for me to want to teach people from other countries. And of these 60 kids, about 20, it didn't really help much. They were so amblyopic. About 20 got ambulatory vision, didn't need to be in an orphanage, and 20 got reading vision. And the Japanese noticed this, were very moved by it. He was invited to the imperial palace and given a scroll by Crown Prince Akihito, who is now just retired as the Emperor of Japan. That was a wonderful influence in the life of many lives that my father had. Well, at the age of 12, I'm in school, a pretty good student, but not that excited. And I had a teacher in the 6th grade named Miss Squire. And she taught me the most important thing I ever learned about being a student. She said, she said, I want all your eyes on my eyes or on the board or whoever else is speaking all the time. Nobody looking out the window. If you did, she would call you on it. She was strict disciplinarian, but she taught you how to pay attention. She also took 4 of us that she saw potential in and took us to the University of California, Berkeley, to see what was going on in the world in various science fields. She was like, if you've seen the movie Auntie Mame, she was like Auntie Mame. There's so many exciting things you could do with your life. And from then on, I was a turned on student because of Miss Squire. Later, when I finished my PhD thesis, I went to visit her in the retirement home where she was, and I showed her. that I had dedicated my PhD thesis to her because she had changed my life. And I wanted her to know that and to get that appreciation. At 14, I went to watch my father in the clinic, where I noticed that he always found out why had the person come, and even if it was unrelated to any real diagnosis, explained to them something that took care of their concern. And then I went to watch him in the operating room, and I thought, wow, this is really interesting surgery. I think I want to be an ophthalmologist. So I realized I could have changed my mind later on, but I thought, I better plan. If I want to achieve that, I better plan to get there. So I made sure that I was doing the things from then on that I needed to get there. And I thought at the time, my career will be going and working with my father and then taking over his practice out in California. God had bigger plans. uh, Shortly afterwards, at the age of 14, I met Carol Crone. And I had been praying to God that he would have me meet the right girls to date until I met the one that I should ask to marry me. Well, at any rate, it was at a church social where they were ice skating, and they brought her friend who was dating my brother, brought her from the school. Went to the school 7 miles away, and they brought her to me and said, she doesn't know how to ice skate. Would you take her hand and lead her around the ice? And I looked at her and I thought, yes. And went on from there. We've been married 59 years, and we have had 3 daughters. At 18, I got turned down by Harvard, I should mention, and that was a turning point. I really had wanted to go to Harvard, but I was interviewed by some Republicans who were English majors. And they looked at the list of books I had put down that influenced me, and they said, tell us the plot of War and Peace. They weren't interested that I had had 5 precincts for John Kennedy in the election. I had shaken his hand or any of that. They were Republicans. They weren't impressed by anything that I had done. And so I got turned down by Harvard and ended up hearing about the 6-year medical program, the first year of it, at Northwestern, which was another turning point for my life. I was accepted into medical school from high school with 2 very intensive years of undergraduate first. During the summers of those 2 years, I worked in biochemistry. The first person I worked for, it wasn't a very good project. But while I was in the Department of Biochemistry, I met Dr. E. Albert Zeller. Dr. Zeller became the major role model for my science side of my life. He was chairman of the department. He was an MD. He was a PhD, primarily working as a biochemist. But he was investigating the role of serotonin in the brain and in platelets. He was integrating science and medicine. He named monoamine oxidase. He had done post-ops with 3 Nobel Prize winners, including Reichstein, who discovered corticosteroids. He's an amazing guy. And so I thought, I want to be a bridge between science and medicine. And that's why I decided then to enter the MD PhD program, which was in its first year. I'm always a guinea pig. And I worked on lens biochemistry. I thought I was going to work on cataract, that there's an enzyme that eats up all the denatured proteins in the lens when they get denatured by light and keeps your lens clear until it gets denatured and you get a nuclear sclerotic cataract. And I was thinking, if I could put the messenger RNA in under the lens capsule, inject it in some way, maybe we could restore cataracts. Well, that path didn't get taken, partly because no company who made intraocular lenses for some reason ever wanted to support my research on trying to cure cataract in another way. Well, my biochemistry committee career just crashed. Everything I went into didn't work. I first, when I arrived at Washington University in St. Louis for my residency, I was going to work on the side with a lens biochemist. And when I got there, I found out he had just left. So there were 9 people picked for the program that year because they thought they would lose one to the draft in Vietnam. And they said, gee, we've got one more than we have really room for. We need somebody to do research for a year. And I had been working like a dog for 9 years, doing 12 years worth of work in 9 years with no time off. And I thought, well, I mean, I have a PhD, I could do this. And they said, but the only project is in glaucoma. And that's how I got into glaucoma. So I did work on steroid sensitivity in glaucoma. We know about steroids in the eye, raising the pressure, but we also studied the sensitivity of lymphocytes to steroids and found that glaucoma patients were twice as sensitive in the normal physiologic range as normal people. Well, I worked on this for 7 or 8 years and finally found out that this wonderful finding was a stress artifact. I only found this out by working with John Baxter from the University of California, who had attended a meeting I went to. And he explained that if you're stressed, the epidermal growth factor level in your blood goes up and has a permissive effect on the steroids that can change your sensitivity to them by a factor of twofold in the physiologic range. Well, one day when I was visiting John Baxter in San Francisco and talking about our work together, he said, I've got to go up to the operating room. There's a patient with a growth hormone secreting tumor, and I'm going to get it and clone it. And he did. And that was the beginning of Genentech and the whole biopharmaceutical industry. Just happened to be there that day. But that was an example of somebody with his creativity in helping to solve a major problem. Well, I then tried to grow trabecular meshwork cells, and you can grow them from normal aged people. It's no problem. In primary open-angle glaucoma eyes that we got, we could keep them in culture, but we couldn't get them to divide. They are at premature senescence. And we published some papers on this about the glycosaminoglycans with Paul Nepper in Chicago, that there are abnormalities in the cells in the meshwork that we still don't understand why it happens, but is responsible for the pressure rise in primary open-angle glaucoma. But we couldn't grow the cells, so I crashed and burned again. But what were the consequences of this? Oh, by the way, I was at New Orleans Academy one time and out jogging with Bob Weinrib, and Bob Weinrib, not unkindly, said, Paul, what happened to you? We thought you were going to really make some contributions. And I said, I tried. The things I did didn't work. Now, you could get discouraged, or you can just find where your niche really is. And I would say if you spend 7 to 9 years in utter frustration, as I did, don't give up. If God's got a plan for you, he's going to find something where you can contribute. Well, it turns out I was contributing, but not the way I expected. One part was that corneal transplant media came out, and it had bicarbonate as the buffer, which is a terrible buffer. Great buffer for your body. You breathe off acid from your metabolism as carbon dioxide. But a lousy way, bicarbonate is a terrible buffer. And these little bottles that they were putting the corneas in, when you took the cap off and the CO2 went away, the pH would go up to 9, 10, and 11, especially when you took it out of the bottle and put it down. You could see the color was changing to purple, which they didn't have a color in it, excuse me. The pH was changing to 10 or 11, and that's not good for the cells. Well, it went off the market for a while, and I talked to our tissue culture guy, and I said, well, gee, we ought to, this has already been worked out by other people. I could be a bridge again. So I replaced 20 of the 26 milliequivalents of bicarbonate with something called HEPI's buffer, which has a pK which buffers pH in just the perfect range for cells in culture. And this avoided CO2 escape and kept the pH stable so the cells weren't harmed. And I put in the color indicator, this orange color indicator, same thing as you use to check your pool pH, because at the concentrations used here, it's not harmful to mammalian cells. And I didn't trust any ophthalmologist to set up a pH meter and calibrate it. So I wanted them to know, okay, if it's orange, it's okay. If it turns purple, there's some bacteria in there that are making it go alkaline, or bacteria in there that are making acid make it turn yellow. So you should only use it if it's orange. So here's a spin-off of those years that God used for good, even though my major work was failing. And there was another spin-off because the people who worked in biochemistry were helping me with tissue culture work. When they asked, is there somebody in the ophthalmology department who could help just look at the eyes of the children with diabetes to see if they have retinopathy. I want to correlate it with hemoglobin A1C, that sort of thing for their diabetes center. I said, okay, you guys help me, I will help you. So part of what I was talking about is you want to benefit others. This wasn't my project. I just thought it was a service. But there was a spinoff. I knew from the literature that it took an average of 15 years to be able to find something in the retina in a diabetic kid if you use an ophthalmoscope. And I thought, well, you know, we have better means of looking. Let me compare ophthalmoscope to angiograms and photography. And after a couple of years of this, I was thinking about it. I thought, well, what if I plotted out the prevalence versus the years that these kids have had the disease? I mean, I had seen them over 3 or 4 years. And when we put the data down, we found ophthalmoscopy, yeah, just like the literature from CARET, it took a long time to get half the people with something. But if you use photography or angiography, it only took 6 or 7 years for half of them to develop something after the onset of their disease. And photography was as good as angiography. And I thought, gee, I wonder if this is important. So I went to talk to Dr. Dowday, who was the head of endocrinology and the editor of Metabolism. And he said, oh my God, this means we can do the diabetes control and complications trial. He had me go talk to Dr. Kipnis, chairman of medicine at Washington University, who was the editor of Diabetes, who asked me, by the way, to write a review article on diabetes, which he's very smart. He realized I have to crash the literature to do that. But it helped me to know the field. And I showed it to him, and he said, well, yes, this means we can do the diabetes control and complications trial. Go talk to Larry Rand in Boston, who's the ophthalmologist involved. And I said, well, okay, I'm running in the marathon in 1979. I will go and talk to him. So I did. And they had me go to NIH, and we showed the data, and they said, yes, this means we can do the trial. And they appointed me to be on the monitoring committee. And sure enough, we did find out that you could very much reduce the prevalence of developing diabetes or the progression of diabetes with tight control. But here again, I was talking about paradoxes in the beginning. Here's a paradox. The paradox is the risk-benefit of treatment. I asked for, and I fought with the biostatisticians for several years to look at the dose response. You know, not everybody you try tight control, you get it. And so you should just pool everybody and do this study. And they did, and they published it in New England Journal of Medicine. I got no credit, but that's not important. It showed a 43% reduction in risk for each point lower of the hemoglobin A1C from 10 to 9, from 9 to 8, from 8 to 7. But 33% more risk of hypoglycemia. And it goes up very steeply here at lower ranges. And the benefit is only slightly improving at the lower levels. Well, you could really improve the care of diabetics if you could go down here, but you wouldn't want to go there. Now that you have patches you can put on a patient's arm that measure continually the glucose level, and you have powerful computers in your pocket and insulin pumps, diabetics now, insulin-dependent diabetics, can easily achieve a level of 6.5 hemoglobin A1C and should have very, very low risk of all the complications of diabetes as a result of this study and dealing with the paradox. We know what the benefit is. Now you can do the benefit better. You can also do the risk better. So now that changes the equation of how aggressive you're going to be in diabetes. Same thing we're going to find in glaucoma. But you want to either have something very safe, has to be effective, and it has to be very safe. And the safer it is, the more you can go for your goal. Well, I found my place at Bascom Palmer in clinical research. First, just as a helper to Rich Parrish, who was then one of our fellows, who took the idea of Mark Blumenkrantz of 5FU. Mark had made a model of proliferative vitreoretinopathy in rabbit eyes with dermal fibroblasts grown in my lab, and found that 5FU could be injected in the vitreous cavity at 5 milligrams, and it wouldn't damage the ER anatomy. you couldn't put it in the anterior chamber, it would destroy the corneal endothelium. But he said, well, but he gave up on that project because you can't inject something in the vitreous cavity every month. Patients wouldn't accept that. Well, that helped to transform glaucoma surgery because, as was shown in the 5FU trial that Rich Parrish headed, you could cut the risk of failure of a glaucoma operation in half with antimetabolites. I came up with the safety valve way of doing a trabeculectomy to avoid early and then late hypotony when your sutures melt in the scleral flap. And in 1988, came up with the term target pressure that you probably have heard. As I'll show you, the concept had been there before from Paul Chandler, but I didn't even know about his work at that time as well. And the concept from the diabetes study, what is the best we can do in glaucoma? Can we halt glaucoma? How much of it is pressure dependent? And I just defined this as the pressure at which people would not have pressure dependent glaucoma damage. Now, the concept's been changed by the Academy to a risk benefit decision of the pressure you're aiming for. And that, of course, will change depending on how safe your treatment is and what that patient actually needs, which we have not until now had a way of knowing, but now we do. And I'll tell you that at the very end of this talk. So stick around for that. I also had there, even though I got the hypotony down to about 4% of my primary cases, I needed a way to fix it when it did happen, when the sclera contracted, and I came up with the 2 sets of stitches repair that we'll show you. Came up with bleb compression stitches to isolate leaks and treat painful blebs, transcorneal needling of scleral flaps, popularized a safe technique for doing 30-gauge needle paracentesis to decompress the eye and angle closure to clear the cornea so you could do the laser iridotomy, or bring the pressure down in a neovascular case before you inject the VEGF. And it's very safe. And then realize that you don't want to cut around in Tenon's capsule by making some small conjunctival flap. You'd like to make a relaxed incision, get behind the insertion of Tenons, get into that potential space, lift up conjunctiva Tenons, pull your scissors down, cut them both off, conjunctiva and Tenons at their insertions, and you get virtually bloodless glaucoma surgery. And then I was involved in the AGIS trial. They would not let me use 5FU, and so I became on the monitoring committee instead of investigator. I said, well, they're going to be my control group, and for the results I was getting. And I said, argued with biostatisticians, I said, we need to do a dose response curve the way we did in the diabetes control and complication trial. After 3 years, they finally agreed to do it. And I'll show you that result that showed you can stop the progression of glaucoma in the vast majority of patients, but it takes a quite low pressure. And also was involved in the CIGIT study as a monitoring committee. The only person on both, so I got to get a perspective on things just by observing the results. And I asked another question there, and we found if you get the pressure quite low, you can actually get some visual field recovery. Wouldn't that be nice? And then most enjoyably of all these things has been training people like Juan Baye, like Margarita Baye, like Rich Parrish, like Steve Getty, Ilana Grajewski, in residency Elizabeth Hodap, and Don Boudin's, all those people that I have been privileged to be part of their education and to learn from them, because 5 of you came from Parrish, and Ilana taught me extracapsular cataract surgery. Listen to your fellows. You know, they're bright people. They can teach you too. You're not the teacher and the source of all knowledge. You are a source of knowing what works as well as it has up until then, and of what the problems are with it, which you better share as well, so they can think of ways to solve those problems. And so Juan, as a resident, and then all these, Margarita, Cristina, Diogenes, Guillermina, Rachel, Coral, Patricia, and Marjorie were all fellows with me for a few months, or I was working with them in one way or another. And how wonderful to see what they've done in the Dominican Republic for glaucoma. Praise God. You know, if I'd gone someplace to do surgery, I could never accomplish what I could accomplish just by training bright, dedicated people like this and seeing what they're going to do. And now I'm still active at 77, unbelievably, as a medical monitor or consultant for the AGIS implant, which is a $50 bar belt from India. Juan and I both were very involved in the Zen. All the training for it was done in his center. And the microshunt, which he did the seminal paper. I mean, he's made more contributions to glaucoma than most glaucoma specialists in the last 10 years. Amazing. Well, hypotony maculopathy. You know, hypotony happens. And when it does, I found out, after listening to Don Gass's explanation of hypotony maculopathy, when the pressure's low in young people where the elastic is, where the sclera is elastic, and in myopes where it's thin, the sclera contracts, and that throws the overlying choroid and retina into folds. So after I had a patient with this, I pondered the problem, how to solve it, and I came up, eureka, with the idea, you probably have to stretch the sclera some. So I would go back to the operating room, put 2 stitches in, groups of stitches, one to make the pressure 8 to 12, which I wanted, and then another group to make it 20 or 25, very carefully calibrating, even with a toner pen in the operating room to make sure it wasn't going to be really too high, and found that after 1 to 4 weeks, it did stretch the sclera. It did get rid of the folds, and this is very effective. 38 out of 40 cases done before 6 months. It can become permanent after 6 months. Were made better. It takes 1 to 4 weeks, so you have to follow the patient weekly to see it. And then laser the second set of stitches or release them if you use releasables to get down closer to your goal. Well, here's a video I was showing, yes, of a patient I went back to revise. And during the surgery, and by the way, now I would do a fornix flap to do the revisions. You actually can do that with an ischemic bleb. It's fine. It goes right down again. But during this case, I had the insight as I sat and pondered the problem. If I put tighter stitches in this scleral flap, I'm going to create tears in the trabecular, in the sclera, maybe a hole, it'll be worse. Or if I put radial stitches in, I may cause a lot of astigmatism. But if I put a horizontal scleral compression stitch anchored at the 2 sides and then adjust the pressured equilibrium flow. You don't adjust flow, you adjust the pressured equilibrium. That's what you really should be trying to do with a trabeculectomy. And then here I had to tighten it a little more, put some fluid through a pre-placed paracentesis, watch the flow to equilibrium, and then estimate the pressure pushing on the cornea with 30 cannula. And I found that I could cure hypotony maculopathy in this way nearly all the time. You may end up with a few little folds, but none in the fovea, and 38 out of 40 people got rid of all their metamorphopsia with this technique. Well, then in 1991, I saw a patient who had a leak. She had had a Shea procedure. There's a full thickness hole, no anti-metabolite, done 27 years before by Dr. Shea. And she had a leak. She hit her eye on the handle of her refrigerator. And I sat and looked at her at the slit lamp. I thought, if only I could wall off that leak and not lose this bleb. Look how scarred this is. How could I pull conjunctiva down to repair it? And the idea occurred to me, se me ocurrió. I could place a stitch. I put it in the cornea, it came out behind the bleb, brought it over the top, tied it tightly, and that stopped this leak and showed me the leak on the other side, so we went down and fixed it. Well, I showed this to David Robinson, who was, Jim Robertson, excuse me, who was a fellow with us, and he said, well, gee, why didn't you just take a bite in the cornea with a mattress stitch and then a bite behind? And I thought, yeah, that's much better than what my idea was. So from then on, we did it his way. And you should call these bleb compression stitches, if you want to put a name on it, it should be Robinson, not Palmberg. But learn from your fellows, even the beginning fellows. You don't expect to learn from. Listen. Engage them in the conversation about problems so they can contribute. Well, this also I found had changed the tissue, and a compression stitch placed over a bleb like this, where the meibomian gland is not able to deposit the oil, therefore the cornea, which is normally like 2/3 water, is going to dry out without that oil on the surface. And the compression stitches turned out to be a wonderful solution for this problem. 9-0 nylon, take a bite in the cornea, go back, take a bite behind, tie it very tight. You have to go over 4 times to lock it and pull it down, and then rotate the knot into the cornea. Have the patient on steroid 4 times a day and on antibiotic until you take it out in 2 to 3 weeks. And you cut here and pull it along the surface because it may migrate into the bleb here. Now, why does this work? Because mechanical stimulation on the bleb, the fibroblasts inside the bleb, mechanical stimulation stimulates the formation of collagen. The DNA is cross-linked by mitomycin. It can't reproduce, but it can produce proteins. And if you mechanically stimulate, you can change. Now, this turned out to be very important with the Zen and the InFocus microshunt because the tip of the tube constantly moving inside Tenon's capsule, if that's where you put it, is going to cause a fibrous cap to form, and you'll have to needle it or revise it. Better to put it under or maybe over the Tenons and off to the side, as Juan discovered. Putting it off to the side gives a pressure that's 1 or 2 points lower than we got in the US trial. We were trying to put them closer to the top. Because if it's under Tenons in that space, the Tenon slides over the sclera. And so we learned from that you can modify blebs. And of course, it was also good for bubble dysesthesia, which Elizabeth Hodap described. You could change the bleb so it didn't capture air and tears as a bubble that was causing discomfort in some patients. Well, here's this patient 2 weeks later, very comfortable. He did not change the pressure in the eye to do this procedure, and it was successful. In, I think it was 73% of the patients, it really solved their problem of discomfort. We also thought of transcorneal needling. I thought, you know, it's bad to put a needle through a bleb to needle a bleb, especially if the place things are failing is at the scleral flap. That's where usually failure starts to happen. And if you find the pressure in the eye is rising, the bleb's getting smaller, but the bleb is soft to touch, then the problem is where the sclera was cut, it's trying to heal. Not in the bed, but at the edges of the margin. And all you really need to do is break those adhesions. So going through the cornea, being parallel to the surface of the bevel's in, then turning in, and then coming out through the ostium, means that you have a non-leaky entry in the cornea. It'd be self-sealing. You haven't made a hole in the bleb. You're not going to get a hypotony because you don't have a hole in the bleb. It's still got a margin, and it usually doesn't bleed. So it's a far better way of needling that kind of bleb, not a Tenon cyst where the pressure in the bleb is the same as the eye, but where it's lower. And this needs usually to be done fairly early after surgery if it starts to fail. Well, then the idea occurred to me, if we've got a patient with a cloudy, steamy cornea and they're in pain, I'd like to be able to reduce the pressure. To do that with a paracentesis. Paracentesis was really known by people. That was not new, but it wasn't being used for this purpose much. And I thought, well, I need a self-sealing incision. So the bevel has to be parallel to the cornea. It can't be vertical bevel because that'll make a groove that will leak. So you have to be, it's very important, you have to be parallel. And you want to go into a phakic eye. You want to go in the left eye. You want to go in around 4 o'clock and aim for 6. You're in the periphery. You can't hurt the lens that way. Very important. Don't go straight in. One fellow did that and stuck a lens because the patient looked towards the needle. Now, what do you tell the patient? You don't tell them, I'm going to stick a needle in your eye. You say, your eye is hurting and your vision's blurry because the pressure is really high in your eye. It's pushing fluid into your cornea. We need to let a little fluid out. And then patients accept it very well. You have to use the needle either hold by the hub or with a syringe without the plunger. You don't suck fluid out. That could flatten the chamber. You let the pressure in the eye drive it out. And it just turns out for serendipitously, oh, by the way, you get till the bevel's in, you're parallel to cornea, then you're parallel to iris. You hold it for about 10 seconds, and then I found the pressure, if you take it right away, is about 12 millimeters of mercury with a tonopen in a fairly narrow range, usually between 8 and 15. Well, the residents have just done over 100 cases of this and found an average pressure of 14. They may not have taken the pressure quite as quickly, but at any rate, very safe. And there was only one patient out of over 100 that had a pressure of even 5, and nobody with a pressure lower than that, no flat chambers, no suprachoroidal hemorrhages. It's a very safe way of doing this and will be publishing their paper shortly. And this is about getting under Tenon's capsule. Here's Tenon's, which is thickest between 10 and 2, and down below between 4 and 8. So if you get underneath Tenon's and get your scissors in and lift up, pull down to the limbus and cut, your only bleeding is going to be right there, not inside Tenon's or conjunctiva. And you'll also get a much more secure closure of both conjunctiva and Tenon's if you cut them together, keep them together, sew them back down together, so that you don't make radial cuts in Tenon's by accident that recesses, leaves you only conjunctiva in a very vulnerable bleb. Well, there are other interactions that you have with people. This was with David Meltzer when he was a resident in Miami. Now, David was a physicist, astrophysicist, who had predicted pulsars. And when they were discovered, in the Nobel Prize lecture, they quote him. And then he decided to go into medicine. I picked him for the program. I was picking the people in St. Louis, along with Elizabeth Hodep, into a very remarkable class of residents. And during his residency, he realized the UGG syndrome was probably due to something he could find the answer to. And he asked me to go and talk to Dr. Becker, the chairman, to get him some money, which I did. That's my only role in this. And he used energy dispersive X-ray analysis to find out that copper and iron were on the surface of intraocular lenses that were causing UGG syndrome. And he had gotten the lenses through the head of the AGIS, who happened to be a doctor in the community, Robert Drews. And he said, well, gee, all you have to do is, this is silvoplastic polish. He looked at the formula of what was there, and he told the head of the company, all you have to do is clean the lenses with ultrasound. And it probably saved the intraocular lens industry, because there was a lot of problem with UGG. And this took care of those problems because you could diagnose what was the result of them. Another interaction was with Peng Kaw. Peng Kaw came to visit me as a student, and I don't remember this, but he does. We sat down for an hour and we talked about the relationship between pressure and the risk of getting worse in glaucoma. And I told him, you know, with mitomycin, and with this valve-like incision, I can get the kind of pressures I want. They seem, if I use a big dose of mitomycin, the blebs last a long time, but the bleb problems, the leaks, the infections, are a terrible problem that I don't have an answer for. Unknown to me, he decided to devote his career to solving that problem. He went home and he figured out that applying mitomycin in a fornix flap with thin sponges in a wide area was much better than the way we're doing it with limbus flaps and a sponge intensely pushed into an area that would give you a high, vulnerable bleb. I heard him give a talk on this in Stockholm. We were both speakers at a meeting. And I went home and I said, gee, I think this guy's got the answer. And I went ahead and did a couple hundred cases the next year his way. And from there on out, found that my blood problems were very much reduced to about 1%. And down from about 8% of some kind of blood problem, light leak. So I was going around the world talking about the AGIS result, and I told people, but use mitomycin the way he did. Years later, he told me when he was knighted by Prince Philip in England, he said, I wouldn't be where I am if it weren't for you. He said, you inspired me to go into wound healing. When I found an answer and I was just a young person, you went around the world and pointed out that I'd found the answer and helped along with other people, I'm sure, to convince people to make this change. And I thought, that's got to be one of the most important contributions I made in my life, was spend 1 hour talking to a student. Don't underestimate students. Think of their potential. Like Miss Squires, there's such an incredible world out there. Get people inspired to think about what they're doing. Well, I want to now talk to you about the paradigm shift in glaucoma, and I better be quicker during this part that's coming. Well, where do paradigm shifts come from? Nobody uses a typewriter anymore. because we have computers. Nobody uses a dial phone. We've got cell phones. So where do these things come from? They come from new understanding of a problem or from disruptive technology. Phaco certainly changed, and intraocular lenses certainly changed cataract. Anti-VEGF agents have certainly, and laser have certainly affected macular degeneration. We couldn't do much for it before. In glaucoma, meds, laser surgery, we've been doing that for 40 years or more. Why? Because of our uncertainty about, does this patient need more intervention? And because of the risks of trabeculectomy in tubes. But I think this is about to change. We are going to know much more about who's progressing or likely to progress, not just to be able to measure it better, and we have safer ways of intervening. That should change everything. So is this patient going to progress? And by the way, this is the way to put drops in the eye. Turn the bottle upside down. Hold it between a finger and thumb. Not like drinking, where you can't find your eye. Turn it upside down, finger and thumb. Pull down the lower lid with your little finger and turn your head up. And you're going to put that drop in the right place. And blinking won't even keep you from putting it in because you've pulled the lower lid down. And I find that I can train 90% of patients to do it well. And if not, their family who is watching says, we'll put it in for them. And then be sure to check if you put somebody on medicine. When they come back, have them do it and show you that they can put in the drops. And of course, tell them to wait 5 minutes. But what is the chance that somebody with a pressure 26 and early damage is going to be okay at 20, 17, 14, or 11? The American Academy advised a 20% reduction. We now know that that's really pretty suboptimal. You really should want to get 30% or more reduction in just about anybody with real glaucoma. But we now have new evidence about optimal treatment, which I'll show you. We have the MIGs, and we have the InFocus and the Zen. And those are safer ways of doing the surgery than a trabeculectomy, particularly for the microshunt. Less cataract and much less hypotony by design. So how do you figure out the relationship? When I was doing my fellowship, I thought, what's a fellow to do? How in 1 year do you get a long-term perspective on a chronic disease? And the only way to do it was to come in after church, learn from the past, look through charts of people who'd been there 10 years or more. And I noticed that people with advanced disease did not do well unless they were below 15 at their visits. And of course, this is not like diabetes or hypertension. Getting in the lower part of the normal range is necessary. Why would that be? Well, I later found out that Paul Chandler had the same kind of thought many years before me, and so I call it Back to the Future. And in 1959, he had given some advice, and then the better summary of all this information for those in glaucoma, you should read Survey of Ophthalmology 1977. And I will send this talk, by the way, to one who will have it available, or anybody wants to send it to me, mitodoc, MITODOC at AOL.com. I will be happy to send you the talk. Well, he said, if you've got advanced glaucoma, damage at both poles, you better get under 15. And the less damage, the less you had to get down. And ocular hypertension, you could usually watch it. The appearance of the disc, how much damage has happened up to now is your big, big clue. How aggressive to be. How aggressive has the disease been? Now, we might ask, how much of glaucoma is pressure dependent? In a UK or United States population, there's a lot of overlap between glaucoma and normal. And if you did a receiver operating characteristic curve, you'd say only a third of glaucoma is due to a different pressure distribution in glaucoma patients. And race matters. It's 3 to 5 times more in black patients than white. But in Japan, 15.6 average pressure of glaucoma, 15.0 of the population in Tsujimi. And 92% of their glaucoma happens in the so-called normal pressure range. But still pressure matters there. They could reduce the risk of progression from 80% down to 4% in a 5 to 10 year follow-up by doing a mitotrab and getting the pressure to 9 or 10. So how much is pressure dependent in glaucoma? And it turns out the surprise is nearly all. And why is that? because notice here, there's only one glaucoma patient in this Caucasian population below 15. So you could move these folks, even in the upper normal range down there, they perhaps would have done better. Now, why would that be? Well, if you get near episcleral venous pressure, you're going to maximize the blood flow, and you're going to, the pressure gradient between the across the lamina curvosa is going to be minimized. So either a mechanical or a vascular theory would predict that a pressure of around 8 to 12 would be optimal, and that's been my goal for a long time in people who I need to operate on. So it's not like diabetes, it's not like hypertension. And using antimetabolites, we were finally able to look at this, and this is the valve incision where we punch out in a, like an old scleral tunnel of a phaco, and the mouth of this canal stops about a ½ millimeter short of the tunnel, and then you can adjust the pressure in the eye at equilibrium flow, putting fluid in, check it, cut more as necessary to get a pressured equilibrium that's about 4 to 6, and you can learn to calibrate yourself. And then you put in the stitches, and you do it again, and you find you can see the flow. Particularly with this valve incision, you get steady flow. Unlike a flap, which will go blorp, blorp, and stop, it's hard to adjust. This is easy to adjust until you get to 8 to 12, which looks like that. And early on, we took a tonopen to the operating room with sterilized, not clean, but sterilized tips in order to calibrate ourselves. And in a large series of patients, Kyoko Ishida from Japan, my brightest fellow ever, put this together and found that in the patients who could do a visual field, we got the pressure down to around 11. We were aiming for 8 to 12. And over the course of 10 years, everybody stays in the study. If you fail and I do something more, you stay in the study. So this is a study of pressure versus damage. And what we found was there was no net loss during up to 10 years of follow-up in these patients. No net change in mean deviation or pattern deviation. Well, how can that be? Because there were some people who looked like they got worse and some looked like they got better. I thought that must be noise, but Kyoko Ishida had the insight, I had to learn from her, that no, at least a good part of this is real. How do you know that? Because it correlated with pressure. And the peak pressure mattered. Now, if you wonder if peak or mean matters, if you do an intervention that could fail, the peak is always going to look better. If you do medical treatment, like early manifest glaucoma trial, it'll look like the mean matters because people are constantly at a particular level of risk. Well, the risk of getting worse on 2 consecutive fields over the course of time was none in the 15 people who always had a pressure of 13 or less, 21% if you ever were 14 to 20, and 38%, small number of people out of that large group if they ever got over 21. And of course, we intervened, so this number would have been much higher if they stayed at that pressure. And I thought, how can there be no net change? And Kyoko had the insight that because you can improve 2 decibels by bringing the pressure down. This is not regression to the mean. It correlates with pressure. And if you're in the intermediate group, it was intermediate, and the other group will stabilize you for a while, but then you get worse. So that gives us another goal. It'd be nice to get some field back in some people. And we were able to show in the AGIS study that, yes, if you're under 18 all the time and you're averaging 12, you ended up having no net visual field loss. And I shared the World Glaucoma Prize for this. They told me I won, and I said, well, wait a minute, that's not fair. Gastroline did all this work. Why don't you go tell him he won and ask if I can share it? And that's what happened. So the right guy got the real credit for doing it. He did have the idea of looking to see what's the best we can do, as we had done with AGIS, had done with diabetes control and complications. Now, obviously, not everybody needs this, but your risk of getting worse, if you don't have some other way of telling progression, is proportional to the pressure in that study. And so we'd like to be here, but we don't want to take risks to get there in people who don't need it. So how would we tell? And by the way, if you just do a treatment like betoxolol and laser, as they did in Sweden, why, yeah, you get an improvement, but not much. Whereas in the United States, where you had a target pressure that had to be at least 30% down and even more in advanced patients, you had no net progression in the medical or surgical groups over the course of 7 years. But if you weren't controlled medically, then they did laser and then they did surgery. They crossed over. So the medical group probably would have been somewhat worse if they hadn't had the crossover. Well, there were about 20% of people looking like they're getting worse in both groups. How can the mean not change and there are people getting worse? There must be noise. Aren't there people who look better? And David Musk, who is a biostatistician who will listen, looked at it and said, yes, it turns out that there are just as many people, almost as many people getting better by 3 decibels as worse. And some of it is real. Some of it is probably noise, but some of it's real because if it's noise, it shouldn't correlate with anything. And it did. It correlates well with pressure, which I'll show you. It also correlates with gender. Women were 60% more likely to get a recovery of visual field. And if you had cardiovascular disease, a previous heart attack or stroke, then we could stabilize you, but you weren't as likely to get anything back. Poor blood flow isn't a good thing. Well, it turned out it correlated with pressure. Here's the people who had the percent of visits, 10 visits in the first 5 years that were better than the 2 baselines by 3 decibels. And as you can see, you had more with a peak pressure of 13 or less than you did at higher pressures. And remember, you would have intervened in these people if they were at a pressure over 18. You didn't stay with that. But how can you tell how much is real? Well, the idea occurred to me, if you subtract the people who look worse from the people who are better, you'll get the answer. And the answer was a dose response curve, a net improvement that at least 12% were better by 3 decibels if your peak was 13 in these mild initial patients with about 5 decibel loss. And the confidence limits are fairly large on this and on the mean deviation in the group. And then as you go to higher pressures, the risk benefit changes into being net negative. And we can't tell in the individual here still, but we can tell by looking at a group of people that this would be advantageous, at least getting to this group, and better yet, getting there if we didn't have the complications of hypotony and low pressures. So we know that at least 2/3 of the people who looked better, it was real, but in other people who looked better, we can't tell. Could have been noise, could have been real. So if one field is worse, as they found out in other studies, you need some other measure of knowing that things are getting worse. Focal loss, which is more convincing, structural change, OCT or disc, or some way of measuring the dying and stressed cells, which would be the very best. And I'm going to show you that that now can be done. And that's what's going to change, I think, it's going to change everything if it pans out fully. I'm going to skip this part and go on to the conclusion. If we were aiming for 13, everybody, we're going to be treating, we'll stabilize their fields. We're going to pay a price. We're going to be treating everyone aggressively to benefit a minority and the offsetting risks from surgery. So either we got to offset the risk from surgery with, say, for things like the microshunt, and or if we had a way of knowing which patients were still getting worse and needed those low pressures, selectively treat those who are losing cells faster than aging. Well, let's imagine it's 2024, maybe 2025, and the FDA has approved the work of Francesco Cordiero, one of my heroes, who came up with DARC. What is DARC? When the cells in the retina are stressed or dying, the annexin receptors come to the surface of the cell. They're not necessarily going to die, but they're at least stressed and on their way. She took annexin, put a fluorescent probe on it, injects it into the arm of a patient, and then looks for the staining of the cells in the retina. and counts them. And in a normal person, you didn't see many. And in a glaucoma patient, you saw more. And it correlated with glaucoma, with progression, with the central corneal thickness, and with age. But this wasn't going to be very practical, taking pictures, sets of stereo photographs and or OCT images and counting the cells that would light up until just this year. They published that it's now been automated. It's able to detect the stress cells more, so you're seeing far more cells. And they were able to distinguish glaucoma patients who were progressing from those who were not. And using the OCT machines you have in your office, if you have the filters for OCTA, either Spectralis or Heidelberg, and the algorithm counts the cells from the image for you in your computer. So now this should be practical. It still needs an FDA trial. I think where would you use it would not be the person with a lot of damage and a pressure of 25. You already know what's you want to do. It's not going to be the person with a pressure of 13 who's very unlikely to get worse. It's those people around 17, 18, 20 who you're just not quite sure if you need to intervene or not, and you're waiting for them to lose another 10% of their visual field or their OCT. You could do this test and say, that person is not losing faster than aging. I'm going to leave them where they are, or I'm going to intervene if they're losing faster. And then after you intervene, you would be able to tell. So my final slide, what's glaucoma care going to be like in the future? Well, we'll still be measuring visual fields, of course, and stage people. We'll still be staging by structure, but being able to stage by cell loss could change everything by making it selective who you need to be more aggressive in. That is going to lead, in my guess, to a paradigm shift. So I'm doing everything I can to make people aware of what she's doing, trying to get company to talk to Genentech, talk to Allergan, people that I know. And I said, please think, Santon, please think of investing in this. We need to get it through the trial. And the design of the trial should be 2 stages. One, look at some people who you know you need to operate on, you knew you didn't, and show the range of response differences. And then another trial, get it on the market showing that it does what it says it does. And then another trial, a longer trial, which may or may not be required for approval, which would look at people where we're not sure what to do and randomize the people, perhaps, to letting the doctor see the result or not to decide whether to intervene or not, and see how, does this really improve the risk benefit ratio by avoiding risks where you don't need them and get the benefit where you did need to intervene better than we're doing now. And of course, having operations that are safer, that cause less cataract and less hypotony, like the microshunt and the Zen for the hypotony side of it, that could make a big difference too in having safer ways of getting down there when we need to do it. Well, thank you very much for your attention. Thank you for the opportunity of being here, sharing my career, my life, my motivation in life, satisfactions that I've had, and I would recommend to all of you, think of ways that you can serve God, you can empower others, and get this wonderful enjoyment out of life that I've had and continue to have. And don't sell yourself short, and certainly don't sell your fellows and residents short. They are the future. Share the problems, what you don't know. One of my fellows visited, I said, what was the most impressive thing after your time at Bascom Palmer? And he said, hearing Dr. Gass say, I don't know. And maybe the second most impressive was hearing Paul Palmberg say, I don't know. That's one of the most important things. Find out what you don't know and find answers for it. And love God and love your fellow man. Thank you. And love yourself by doing those 2 things first.
Paul, as always, you are amazing. Amazing. Thank you. I would like for the panel to open their microphones and videos because we have a few minutes to interact. And Margarita particularly, I know would like to say something. But you have given an outstanding lecture, one of those memorable talks that will forever be in my mind and in my memory. For Margarita.
Dear Dr. Palmberg, thank you for this impressive lecture. I am honored to address to you today a day in which our hospital pays tribute to you as a most esteemed physician and educator. First, I want to thank you for having welcomed me into your home as one of the family many years ago in 1994, when I had the opportunity to rotate with you at the Bascom-Palmer Eye Institute. I still remember when I felt ill, you took care of me, brought me food and medicine to my room. I miss your teachings and advice on our way to and from the hospital. It was a wonderful time when I learned a lot from the best. An extraordinary human being, both personally and professionally. Humble, dedicated, curious researcher, always looking for excellence. But in my experience, what makes you a most unique physician is your dedication and time that you give to your patients. You were also patient with the students and doctors that had the privilege to rotate with you. Some of us have been lucky to continue learning from you throughout the years. We have been blessed here in Elias Santana Hospital with your presence and guidance, and we are thankful for it. Thank you again for all you have given to us, and God bless you. Thank you.
Dios bendiga.
Truly, Paul, you were amazing. I'm going to go up on my screen now.
I want to say one other thing. This was a wonderful thing for my family to get to be part of my career, to contribute by also being helpful to the people who stayed in our house, and to get to know people from other cultures. For my daughters, this was fantastic. And it let my wife have a mission as well, which I really recommend this if you have room in your house to have visitors come and study with you, because it's so good for your family to involve them so they have a contribution and an appreciation. Yeah, sorry. Anyway, go ahead.
Thank you.
Thank you. Thank you, Carol, I know she's listening now. I'm going to share my screen now. I just have my son, Juan, and my first adopted son, Carlos, the one and the first and only. And of course, you weren't here, Carlos, when Paul gave his testimony about teaching you how to do a trabeculectomy, which normally would take 35 minutes, and you did it in like in no time.
Yeah, he did it in 15, and I said, see what a good teacher I am. Mine had taken 40.
So I'm going to share my screen now. The lecture that I would like to have. Where are you? This? No. Can you see my screen now, guys? Are you
No.
able to see my screen? No?
I see you.
Yes, yes.
Let's do it again. Let's do it again. Well, let me open Paul. And let's go back to Zoom. And share the screen. Now you're talking. Perfect. So, as you can imagine, Paul, we have a mutual admiration club here, because you've been my hero from the first day that I was a resident at Bascom-Palmer, and you were the attending that would rotate with the residents, the newcoming residents, 6 of us at the time at Bascom Palmer. And what I have learned over the years goes beyond medicine, goes beyond ophthalmology, goes beyond science. What I've learned from you is wisdom. I have learned many things that you don't learn normally. I always say is Paul Palmberg is at his best always, or as you did today in your own living room, sharing with us. So I did want your family to be listening in on what I have to say about you, because it turns out you have a huge and bigger family throughout Latin America and the rest of the world. And at least here in the Dominican Republic, I'm sorry, you got a lot of children. And
grandchildren, more important.
That sounds weird.
And we were making a list of the people that have been in fellowship training with you. And I think the list goes something like you have 170 fellows throughout Latin America.
107.
7, okay?
Yeah.
Keep me straight, you're the data monitor. So it's a huge family. And as always, you're the heart and the spirit of the Curso Interamericano. And I appreciate Carol being here and Alana listening to this, because again, Glaucoma Day at Curso, your ability to choose the lecturers, the ability to project to the Latin American audience that which is the Bascom Palmer Eye Institute is just part of your gift. You're the ambassador of Latin America for the Bascom Palmer Eye Institute. No question about it. And even though it is #1 in the United States, it is also #1 in Latin America. Now it's been 40 years of the Inter-American course. Got this picture through ophthalmology published by Bascom Palmer when you were with Don Francisco. It's a yearly occurrence. Of course, there's Carol and Dr. Alfonso as well. But I want you, most people don't understand what I mean by the fact that your teaching is best done when you're one-to-one. And this is just a little brief excerpt of when you were here in November.
The pressure gradient between the
And I hope you can hear
and the subconjunctival space, about 6 to 8 millimeters of mercury, enough to keep the chamber formed, but not to add too much resistance. This tube is designed at normal.
So I'm getting poor transmission of sound, but basically what you're describing to me is the importance of the in-focus microshunt in its passage through the sclera and the gradient of intraocular pressure that is created without going into hypotony. And these are the kinds of explanations that only take place in the hallway. And then it reminded me of this famous photograph, which was the first glaucoma society that there was in the world. And the importance of this picture, one that's in black and white, so it tells you how old it is. It took place in Europe. I think it was either in or someplace in Holland, in the Scandinavian country. But Dr. Drans annotated for the Glaucoma Society the members that assisted this meeting. And I would like to point out #6 and #7, Becker and Schaefer, and also the presence of #26, young Doug Anderson.
Yeah.
Young Doug Anderson. And of course, there are other people like Becker and Armley, Barani, people that are the giants of glaucoma. But the importance of the picture is that these leaders in glaucoma passed on their knowledge to us. And in your case, you're a direct pupil to Anderson, and of course, Richard is your pupil, and so on and so forth. And so are we here in the Dominican Republic. But for us in Latin America, you are Tio Paul. You are Uncle Paul. You're the one that we consult when we need to know things. Like here at the Curso de Don Francisco, but most people in the States don't know that you are also the leader of symposiums and conferences related to glaucoma here in Mexico and Brazil, all the way down to Argentina and throughout the world. And this photograph, which I love because it's got the handles of a scissor, cutting doctors, of course, in Santiago de los Caballeros in the Dominican Republic, with only a few of your alumni here in the DR. So over the years, you have been in Santo Domingo 15 times. Last time was in December when we were teaching the fellows here and the residents on how to introduce the in-focus microshunt. And you've some testimonies that you'll...
Hi, Dr. Palmberg. Thank you for giving us the privilege to learn from you, not only the teaching related to glaucoma, but also your ethical behavior to care for the well-being of the patients. Thank you, Tio Paul, for a life dedicated to service and mentoring with an inspiration devotion. Hi, Dr. Palmberg.
So here it is again. One of your great students, Nelly Grace Olivo.
Nosotros. Personalmente, las veces que he podido compartir con el doctor, me he fijado en su atención al detalle, en siempre pensar un paso más adelante. Gracias, doctor, por todo lo que nos ha podido transmitir y espero que Dios le bendiga grandemente y le provea mucha salud y muchos años más para seguir teniéndolo entre nosotros. Gracias. Nosotros.
Or this testimony from Dr. Bellis, she's from Colombia, but one of my residents in the DR, about how you increase through your teachings the knowledge and love for ophthalmology. Or one of the sons of our faculty members who was there at the Curso Básico in Puerto Rico that most people don't know, that you go every year, you've probably done it for the last 35 years, at the Curso Básico. And this is a typical hallway at the University of Puerto Rico as you are giving these talks. Or when you were here, when teaching here, Dr. Margarita Arbaje, how to do an in-focus microshunt, as you taught me.
The width of it will limit the, you still have a press fit. Yeah.
Well, I used to just go...
Just very shallow, yeah, very shallow. Very shallow. And then get as close to the limits as you feel comfortable getting.
I can do it.
Okay.
That's enough.
You were here for that as well. This happened about 8 years ago. So this is not something that just happened. You've taught my fellows, you've taught my residents, you've taught my people. And here's a testimony from someone who's crazy about it.
Today, I want to thank Dr. Paul Palmberg for everything that I have learned from you during my rotation at Bascom Palmberg. I will always remember you as the best and dedicated doctor who cared about your patient and all people around you. I'm very proud to have been your student, and I consider you as the best and master of glaucoma. Thank you for all. Congratulations today.
And I don't know if you saw the chat where you had some of the residents from Bascom Palmer saying that they miss you in the operating room. And I know why, because you're just such an outstanding teacher. And when it comes to publications, I just got into the academia here, and it shows how many times you get cited for the articles that you've participated, from the mitomycin, from the 5FU, from the work with the TVT, from the work with the data monitoring for the Zen, the InFocus, the SiPass. It goes on and on and on. One time you were here, this must have happened about 6 years ago, and that day we did 10 cases of Zen. We were training the group that was to do the FDA study from the United States. You probably recognize Steve Bold standing there, and Don Boudin, Sangetti, and Rachel is there with, and there were 10 patients. All 10 had a Zen implant, and all 10 had the IOP at 10 millimeters of mercury. It was just a fantastic experience. Dr. Corona and Albuquerque are there as well. Or in the meeting in Amsterdam, when Isabel Reis, who was the co-participant in the initial investigation with the in-focus microshunt, and this was recommended. But what most people don't know is that 35 years ago, you donated your collection of archives for ophthalmology that belonged to your father and that you added onto your collection because you didn't need it, having the library at Bascom Palmer. And these were the residents at the time in 1980, 85, when we started doing this. And here's a comment from Dr. Lisa de la Mota: better than 1,000 days of diligent study is one day with a great teacher. Thank you, Dr. Palmberg. This is the kind of reaction we're getting to those moments when you were there. Here at the MIGS session at Bascom Palmer, where we're teaching our fellows on, here Dr. Patricia Franco on how to use MIGS, or with Dr. Lucinda Alvarado when you came in November. Or in the wet lab, with Dr. Rachel Rodriguez, Raquel, and Mariel Warden, Giselle Morales, Guillermina Mendez. These are the people that are really your daughters, your sons, your family, your extended family. And Margarita just said it, you are the teacher of teachers for us all here in the Dominican Republic. And we learn more in the hallways, as I mentioned, but I found this talk that you gave at the Bascom Palmer Eye Institute, and it was reconsidering anatomy. Of course, in your presentation just now, you mentioned some of the points on the type of sutures that you utilize, how to dissect tenons, the use of the Pencott technique. But you can see that the people that were there for the presentations, Virgilio Galvez from Colombia, or here's your faculty, Doug Anderson and Elena and Renana Katz and Richard Parrish from the Bascom Palmer Eye Institute. You probably just saw this lecture and slide that you always show about the difference when you utilize mitomycin C with the Pencott technique versus when you utilize the placement of the mitomycin C sponges in a concentrated, getting an elevated, uncomfortable bleb versus a low, shallow, diffuse bleb with lower intraocular pressure. And Olzoro is the other name that, or nickname that you get for using the 30 gauge needle for a number of things, from needling of blebs, from decompressing the chamber in acute angle closure, from reducing the pressure, from cutting sutures, for eliminating synechia, for reopening valves. It goes on and on. You came in December and taught us how to ligate the barbell, which is just a fine little detail that you don't do correctly. You end up with an intraocular pressure of 0 and hypotony, and how it is important to test for this ligation as you are doing it. But I know Paul, the Christian Paul, the elder in his church, when I called him on Monday, he was on his way to church to deliver food and drinks to the people that are right now suffering in the community in Miami. And his church was actually doing volunteer work to try to deliver this food to those that were needy, which most people think there are a few, but there are actually many. So when I decided to pay tribute to you, Paul, in these words of recognition, it's because you really are an incredible person, not only as a scientist, not only as a friend, not only as a teacher. You are just outstanding. And my residents, in their full gear now, have something to say.
Thank you.
Thank you, Paul. You have been special, and been special in my life ever since that first day when I was a resident in the ophthalmology clinic at Bascom Palmer.
Oh. Thanks, guys.
Mi héroe, Tío Paul.
You know, confirmation is fun, but seeing what God has accomplished, maybe some through me, a lot through the people that I was privileged to play some part in their lives, is so rewarding. And when people think, when you are trying to glorify God and empower others, that's really being the best thing you can do for yourself. And being creative in what you do and in trying to find ways to serve others, like having them come stay in our house. So we could talk in the car on the way to work and back. Thinking of having people come from other countries to be here instead of just going and talking someplace else so they could get an in-depth experience. So that maybe we could kind of like put ourselves out of business of taking care of international patients, because we've helped empower people in those countries. So much better for the patients, so much better for the doctors. You know, it does make you think that God had a plan for your life.
Oh, you know you did. I had asked Carlos and Nicole, this is something that I record. I made the mistake of recording the interview in Spanish, and this session has been all in English. And I said, Carlos, how did you achieve true happiness?
Well, the way I figure is that happiness is when you go further beyond of your own expectations. Is you think of a plan, you say, I'm going to go here and do this, and then suddenly you realize that you've gone way far beyond of what you actually plan to do. It's like what we do at the hospital. It's just Dr. Baye and me when we started. Look at us now, where we've gone, how far we've gone. It makes you wonder if you can go even further than this. And I know we are going in that direction. So looking back at what we've achieved in the hospital and in our career and everything I've been able to do because of what Dr. Baye decided one day he wanted to do with me, it's difficult to put it in just one word, but it's certainly, it's a fulfillment feeling that you get to see what we've gone, where we've gone and what we've done with so many people, how many people we've been able to teach and work with and train and send them out there is just gone far beyond of our own expectations. I don't think even Dr. Baye knew that we were going to be going this far when we first started. All the people internationally that we trained at the hospital that we related to, they are doing the same thing we are in other places. So it's like when they ask me, you know, how many cases of cataracts have you done? It's impossible to count because you have to relate in terms of how many people I've taught to do cataract surgery, and they are doing the same thing in other places. So every time they operate, it's like there's part of it of what they do, of what I give them. So I have no numbers. I stopped counting in 2007, and it's just because if I hadn't learned enough by then, I don't think I could learn anymore from there on. But
I should mention that Juan has been very creative by having several of the residents each year be from other countries. Ethiopia, India, Azerbaijan, and he has, in essence, done exactly the same thing of empowering people in other countries. Very creative to have done that.
You know that, Dr.
I should also mention that in times of trouble, and we've talked about all the good stuff here today, but it's also important to have God with you when there are tough times, like our daughter who died of leukemia. To be there, to know that we're going to see her again, and to be there to be with her during that time. And that was a time when I could share my faith with people by telling them to ask them to pray with us. And I could share my faith with Muslims and Egypt and Saudi Arabia and India and Hindus and other people and learn about their faiths. You know, you get real when things are tough too. When a lot of the things I was trying to do in the lab failed, and I just had to pray, God, show me what to do. How can I make a contribution? And not to be discouraged if things don't go great right away. Haven't shared that up till now, but that's also important, is the comfort of being in touch with life and in touch with God.
Willie, I know that you've seen the evolution of eye care in San Domingo ever since we started back in 1984. And you've seen the impact of people like Paul. And I just wanted to hear from you, because I'm going to go into a sharing a screen in just a few seconds. Willie?
Not on. I can hear you, but I can't.
Hernan needs to start our video.
Start the video.
There we go.
There you are.
Hello, dressed.
Thank you, Juan. We were off the edge there, and we're back now. So yeah, I've gone a couple of times, Paul, when you were lecturing, and of course I listened as well as I could listen, and to get away from anybody calling me doctor at all, which of course I deny because that's the truth. And then it was one of the things that you said there. I now understand that your humor is spread across everything, which is a beautiful thing. And I remember one day there, the last time I saw you, was somebody asked a question. One of the residents asked a question. And I didn't know where the question came from, but you said, you know, I don't really remember, but ask Juan because he never forgets anything. I thought that was a great answer. And I suspected that you actually did know what he was talking, what was being asked, but at the same time, it is true. Juan doesn't forget anything. And I can't help but, Juan, to reflect on my own self whenever you are faced with Paul Palmberg, because there are some similarities that when he was a child, things came together in a certain way. And mine maybe was different from his in a big way, finally. But in that, when I was 9 years old, I was in church, and a missionary. I was used to seeing missionaries because my folks always brought missionaries to our house. So I listened to missionaries I got from all over the world. And in that night, that missionary said, does anybody here, I want you to raise your hand if anybody here feels that God wants them to be a missionary. Well, I raised my hand, and I was 9 years old, and no one else raised their hand. And the missionary didn't see my hand, but that's what I truly believed, and I've never, ever gotten away from that. And so what I have on Paul is 1 year, because I'm 78. We're still underway too, Paul. So it's been a great privilege to listen to you today and tie the thing together. What I say to our graduates, and I'm sure that on graduation night, whenever I have a little 5-minute thing, Juan does all the technical stuff, and he and I are always amazed. We never consult with one another. What are we going to talk about? We don't do that. And God has brought us together time after time after time after time. And I would say, without fail, I know Juan would say the same thing, that what we are saying rings the same bell around the world. And so it's a delightful thing to know that. And the thing that I've repeated and repeated and repeated, and I will say again, the thing to do is to follow Jesus. You're saying it all the way through, and that's a beautiful thing. And people, I know it can get scary. There are plenty of scary things out there. And right now there's a bunch of people that are really worried about this pandemic and so forth. But hey, this is the world we live in, and this is the world that Jesus walks with us. He says, you're going to face all kinds of stuff that is really bad or discouraging. And your discouraging numbers were amazing. I mean, what you said about that was, I just loved it. It was a spectacular. Continue, you go on, because that's the way it is. And we're warned beforehand. If you follow Jesus, understand you will go through very hard times. There will be difficulty. Not everything is blue sky and open sea. And so I would say to all of our graduates out there, and now I'm aware that a bunch of them are out there listening to you tonight, Paul, and or today, it's still daytime here. And I will say again, follow Jesus. Yes, what do we do here? What we do here is we have disciples that when they leave, they are disciples with golden hands. And what we want simultaneously is that they all follow Jesus, because then everything is blessed. The hard times, the bad times, the good times, they become, that's not the deal. The deal is we are at peace because we trust our Lord. And today I say to all of you, let us follow Jesus.
Amen. Thank you, Willie. I'm going to share screen now because actually I promised Paul it was only going to be an hour and a half, but we're enjoying it so much of it that we're stretching it. So I better share what comes next, which is something that I kind of prepared before, which is an interview with you, with Willie and Janice. Somehow I need to escape here. So I'm going to share my screen. There. There we go. There we go. So this is something that took place a couple of weeks ago. Willie and Janice, I asked them to go to the hospital. Of course, we've been on isolation. And so I asked them and Nicole a few questions about how it all began. Most people do not realize that it all began way back in 1984. Actually, it began before that, talking about God's plan, because there are things that happened in the Dominican Republic at around that time that had nothing to do with ophthalmology, but it did have to do with missionaries and missionary work in our country. So let me begin with this pre-recorded testimony.
What do you want to start with?
So Willie, what was it like before you came to the DR? What were you doing in the States? Where were you? How did you two meet? What was your calling?
My calling was when I was 9 years old. From that point on, I knew that I should be a missionary. I believe missionaries were the only people in the world that could do anything. And Janice was further off. She's almost 6 years younger than I am. And so I had her, I looked at her and I told my brother, I said, have you seen this girl at church? And he hadn't. And I said, you ought to look at it, you ought to see her. And so we were out on a Christmas singing time when you visit people's houses and sing to them and so forth at Christmas time. And we do that in a big truck, with an open truck with hay and all on the truck. And then we would go from house to house and sing to people. And it was quite nice. And so Janice happened to be standing in the front corner of the bed of the truck. In other words, right behind the cab. And all of a sudden I noticed that my brother has moved in on her. And I looked at that and I said, that's not gonna be. And I cut right across the truck, edged him out, and haven't looked back.
So that was Willie's calling. He said, missionaries can do anything. You heard him. And this is Janice's calling.
I finally understood what the Lord was saying. I had never had a conversation in the same way that I had had at that moment. And he was saying, I want you to be a missionary. And I said, well, Lord, we are going to be a minister and I'm going to be his wife. And that's what we really understood was going to happen. And he says, I want you, and you'll have to decide. When I finally was willing to say yes, even though there were tears because I knew what that meant for me, that Willie and I would probably have to break up.
We need to break in here.
So the calling was there. Willie had the calling. Janice had the calling. I want to hear it. There we go.
August 1, 1970. You came to the DR. Yeah. And where were you? Santo Domingo. bunch of other missionaries that we didn't know at all. And out of the blue one morning, there comes a knock at our door. We're staying in another couple's house of the mission. And the knock on the door, and I answer the door. And a man says, my name is John Shannon. I would like to talk to you. August 1.
So that was the knock on the door. John Shannon had been a missionary in the Dominican Republic for 15 years. He was, or maybe longer. And he was directing medical group missions that would go into the interior of the country, primarily to dispense eyeglasses, but at least 3-4 times a year, they would have short-term groups that would, missions or groups that would work and operate.
I remember Nicole telling the stories about how he had to go up to the second floor because the ocean waves were going in. What was all that? Oh, yeah, bathroom ground.
And they got hit by the hurricane.
And it was the only, really the only space that
No.
would not be trash.
¿Qué pasó?
We had 2 doors, an outside door and
Están compartiendo.
Perdió el Zoom. O sea, eso no sale como usuario.
Se ven ustedes tres nada más. Pero no se ve el share screen.
¿Qué pasó? Entonces, ¿qué sería lo que pasó? Se salió.
Salte de la presentación.
Entra Zoom.
Dale para acá arriba.
Ahí está.
Ahí. Dale entra Zoom. Compartir.
Compartir pantalla.
No.
La guía positiva.
Esto no es.
Desde la.
El video está fuera de ahí.
Okay. I was just told that I was not transmitting at all. Y que pudieran oír el testimonio de ninguno de ellos.
Y la primera sí. El primer video sí.
Okay. So I'm going to go back to where I left off. Apparently my PowerPoint presentation came off soon. Thank you for rescuing me, Hernan. So hear it again.
I finally understood what the Lord was saying. I had never had a conversation in the same way that I had had at that moment. And he was saying, I want you to be a missionary. And I said, well, Lord, we are going to be a minister and I'm going to be his wife. And that's what we really understood was going to happen. And he says, I want you.
So that is her calling, Willie's calling as well. And I hope I don't lose it as I did before. And then things begin to happen in the lives of you guys, Janice, who were at the time.
And as that trip came to an end and I was finally back in Phoenix, I had at that moment decided that whatever the Lord wanted, I knew that.
And they decide to come to the Dominican Republic.
August 1, 1971.
You came to the DR.
Yeah.
And where were you? San Domingo in the countryside?
Yeah, well, we were in Santo Domingo to begin with. And the other missionaries were spread around the country. And then out of the blue, there were a bunch of other missionaries that we didn't know at all. And out of the blue one morning, there comes a knock at our door. We're staying in another couple's house of the mission. And the knock on the door, and I answer the door, and a man.
And that was the visit from John Shannon. John Shannon had been a missionary in the Dominican Republic for a number of years, and he needed an assistant, a person he could trust to help him with the groups that were coming to do short-term, 2 weeks at a time, missionary work in different places in the Dominican Republic, primarily to do cataract surgery, glaucoma surgery, and pterygium surgery. The skin on your and then the Dominican Republic gets hit by a hurricane. And the mission clinic in La Posada gets destroyed. Willie and Janice almost get killed. They hide in the bathroom in order to do so. And around about 1984 is our first.
So how Dr. Valle and you guys met?
It was a coincidence. A God coincidence. In other words, it was manipulated by God, and he brought us together in Miami Airport.
But before we got to Miami, I get a phone call, and Willie is in Nepal.
No,
Philippines.
The Philippines. Back in those days, as we mentioned before, phone calls and all of that was, first of all, very, very expensive, and getting a hold of anybody, I never called Willie as an emergency. But I get this call from this man that says, I'm Dr. Juan Valle, and I would like to speak with Willie Hunter. And I said, well, Willie is not here. He's in the Philippines right now. And he said, well, can I call him? And I says, no, there's no way to really call him. I don't remember exactly how to even get a hold of him. But he said, well, I need to talk to him. And I says, well, he'll be coming through the Miami airport, and he's going to be in the line.
So we met at Miami Airport, Willie and I, with John Shannon, with Hollis Clark. Hollis Clark was to become a missionary in Haiti. I was to be returned to the Dominican Republic first in December of '84 as on a visit. And this is when things started.
So how Dr. Valle and you guys met?
I got to the next one. So in 1985, Madonna Yates, here in a photograph, had published her book, The $1 Million Vacation, from trips to Central America and to the Caribbean. Work began at the Elias Antenna Center. We would start seeing 30 to 50 patients a day. Of course, now it's more like 400 a day during the pandemic, but just before the pandemic, we were at 800 to 900 visits a day. And Paul, listen to this. Half of the patients that come to our hospital have glaucoma. So here's in the testimony of where our hospital was at in 1984. It was at cinder block level for the guest house. This was our waiting area. And it was all barren. It was an old sugar cane plantation where it was built. There was no power in the hospital. We had to buy 21 light poles so that we could reach the central lines and also our transformers. And if you can see the surrounding, it was a farm-like hospital clinic, very different from what we have today. This is July of 1985. And here's the interesting part. So what happened then after Willie and I visited here, we got to meet each other, and I got to see the project, which was all in plans, and this was made with the money that was donated after the hurricane. Antonio Guzman donated the land that was out here in Los Alcarrizos, used to be a sugarcane for Rio Jaina, for the Sugar Corporation staff. And Gills calls me and has a donation in cash to set up, it was 3 examining lanes, 2 operating tables with microscopes, ultrasound, laser, and a bunch of sutures and intraocular lenses, and all that you needed so that we could set up the clinic upon my return in July of the next year.
And we have not finished the surgical area. And in one big, nice surprise, somebody had poured the floor of one of them wrong, and they had poured it too deep. So the shore thickness, it seems like it was this much. How much was it? You know exactly. It's about 1.5 this thick.
Concrete, rock hard.
And so,
but the reason was not a mistake. They felt that because we were on a swamp,
yeah,
that we needed to create a ship-like structure that would navigate. And it turned out he needed a key. So we ended up building Noah's Ark. So what happened then after Willie and I visited here, we got to meet each other, and I got to see that the project, which was all in plans, and this was made with the money that was donated after the hurricane. Antonio Guzman donated the land that was out here in Los Alcarrizos, used to be a sugar cane. So here are pictures of our original residents, which the idea of choosing residents and knowing whom to pick and whom to train was critical. You see Dr. Burgess, when he was only a young boy then. Dr. Dworkson is in Paraguay. Our techs, we started an ophthalmic technician program, and we've trained more than 300 technicians. And here are a few words about how you choose these people. So now we have Janice on board. Willie's the president of the board of directors. One of the things that we needed was an admissions committee, a committee that could select our candidates. I knew from past experience that the raw material you put into the production was the key element. If you choose your soldiers well, you end up with an outstanding army. And so the selection process from day one at this hospital had been us three. And it was very interesting because Janice would see things that I did not see. I would see things, of course, I was looking at the medical side and surgical ability and interaction with patients. She was looking at the interpersonal, the feelings, and she would come out with things that nobody in the interview would pick up. And Willie would come with the spiritual side, and he would come up with, this person has got a goal that is sincere. Oh no, this person is probably just out here to make money, and he doesn't care about so much ophthalmology and the poor, but rather, and we wanted to also have people from the international. So now we have Janice on board. Willie's. So then our initial residents, as they would go into their second or third year, I would start asking them to specialize. And then, of course, I would send them away for fellowship training. And they would come back and have oculoplastics and retina and glaucoma. And we changed the way ophthalmology was taught in the Dominican Republic. We changed also the basic tenets that ophthalmology was only a bag of instruments to do intracapsular surgery, introduction of lasers, ultrasound. It was a revolution in terms of everything that we did, not only in surgery, going from intracap to extracap at the time, but also in the diagnostic approach to diseases like glaucoma. Our hospital was the only one with a visual field instrument at the time. Criteria and protocols were set up for the diagnosis in all the specialties. And we started to train. And the Elias Santana Hospital truly changed the way things were done in the Dominican Republic. We went from doing 750 cataracts a year as a country to 30,000 cataract operations as a country. And it all began with that mission, a group of missionaries, Willie and Janice, and their desire to help, and the motivation and the legacy that I inherited from Dr. Norton and Dr. Gass and people like you, Paul, that made it all happen. And this is the story that I wanted to tell. So I'm going to stop sharing screen and open it again for you to comment, Willie. You can open your microphones now.
That what it is.
So you need to open their microphone.
No puedo abrir mi video. Ahora.
We're back again.
Okay.
I can hear you. Or
Dr. Palmberg está?
Palmberg shut down right now. So Willie,
okay.
I had a little technical difficulty there with the Zoom. Apparently it got disconnected, but I got the gist of it all. And part of it is that I wanted people to hear that even in these times of the pandemic, when things seem to so bleak and so many people are without hope, it was a lot harder way back then because there was nothing. At least now we know how to do it.
Now there's everything.
Yes.
The thing that I would say right now is, as you know, I'm not retired, for one thing. And there are a handful of us that are trying to move forward with famous or maybe infamous idea of having 500 centers in the world by 2050. And I would like to do the math for you, that in 2050, if we reach that, we're about 40 right now in the world. And if we reach 500 by then, I will be 108 years old. And I'm looking forward to it. And I do believe that there are people that among the graduates that are listening right now, you may want to step up and following Jesus and move to another country. From Peru, from Ecuador, from all of the places where you are now. And some are, I think, maybe if you want to talk to us about it, I think we can set things up. One thing, for example, we've got 2 of our people, graduates in Ethiopia, in Addis Ababa. And to give you an idea of what they face, it is not nothing, because they are there. And they are there with John Kempen from Harvard, Scott, I can't remember his last name now, Scott from North Carolina, and they both professors, and then one Ethiopian who is probably the best known Ethiopian ophthalmologist in anywhere. And they are there, and they're moving to get things started up. I would love
Scott Lawrence. We got words to the chat from Nahum. Scott Lawrence.
There you go. And it would be really nice. But here's the thing. I asked Nahum, for example, how many ophthalmologists are in Ethiopia? He said 150. And I said, well, how many of those do surgery? He said 75. And I said, well, how many of those do surgery well? Whatever surgery. And he said 50%. And I said, so what we're saying here is that we are setting up here now to attack a problem where 110 million people have 37.5 ophthalmologists that can actually take care of them. And we need to move not only there in Addis Ababa, but out farther away. Ethiopia is a big place, really big. And you could not, it's not like in the Dominican Republic where Oslo is 100 kilometers away. It's hundreds of kilometers away for other big areas where lots of people are. So that would be a good example of what is out there. There's a lot to do. There's a lot.
Well, you said it, missionaries can do anything.
Absolutely.
We need to close because otherwise Paul's going to go hungry and we're going to lose our audience as well. But Paul, I just wanted you to have a heartfelt tribute to what you mean to us and for people to know that you are very special. And I want to thank you for every little bit of effort and work that you've done in your life. It's been worthwhile. Thank you.
I feel hugged. And I send hugs to all of you. Virus-free hugs. God bless you.
I got mine around here too.
And thank you so much. This is very meaningful time for me.
Thank you.
Thank you. Goodbye. Thank you, everybody.
Bye-bye.
We can share it later. Thank you.
Yeah, send me a copy.
Okay.